Hello everyone. Welcome back to this series of lectures in endocrinology. Today we'll be moving on to another interesting topic, which is your Men and Mechune syndromes. So let's begin. So what is this Men syndrome, or what does Men stand for? What is this Men syndrome and what does Men stand for? Men stands for Multiple Endocrine Neoplasia. So it stands for Multiple Endocrine Neoplasia, which means that there are multiple tumors which are arising from different endocrine glands. So let us look at what is the definition. So in Men syndrome, there is a predilection for tumors involving two or more endocrine glands. Okay, so it can be the thyroid, parathyroid, pituitary, pancreas. So any endocrine gland can be involved. So what is Mechune syndrome then? So Mechune syndrome is basically a relatively new term that has come up. So Mechune syndrome stands for Multiple Endocrine and Other Organ Neoplasm. Multiple endocrine, and it's not only the endocrine glands but the other organs are also involved in your Mechune syndromes. So let us look at the diagnostic criteria for Men syndrome. The diagnostic criteria of Men syndrome comprises of clinical features of two or more tumors arising from endocrine glands. Yes. Then they have a familial pattern. And all of them are inherited in an autosomal dominant pattern. Okay. So all of them have an autosomal dominant pattern of inheritance. Then if you do the genetic analysis, the only way to diagnose them is a definitive genetic analysis, which will come positive in these Men syndromes for specific mutations. Okay, what are those mutations we will be looking at? So how do you classify Men syndrome? Men syndrome is classified as 1, 2, 3 and 4. 2 is classified as 2A and 2B, and it is this Men syndrome 2B which is also called as Men 3. So Men syndrome 2B is also called as Men 3. Clear? So till here we have understood what is Men, what is Mechune, what is the classification of Men syndrome and the criteria for diagnosis of Men syndrome. Now let us look at the first type of Men syndrome, which is your Men 1. Men 1 syndrome is also called as Wermer syndrome. It is also called as Wermer syndrome. Okay. What is the gene that is involved? It is a mutation of the menin gene. It is a mutation of the menin gene present on chromosome number 11. It is a mutation of the menin gene present on chromosome number 11, and it is inherited in an autosomal dominant pattern. The triad of Men 1 syndrome, if you have to remember Men 1 syndrome, there are three clinical characteristics that you have to definitely remember, or the top 3 tumors in Men syndrome. So this is remembered by the mnemonic 3 P's. So what are they? They are Parathyroid Adenoma, Pituitary Tumors, and Pancreatic Tumors. So we have parathyroid tumors, pituitary tumors and pancreatic tumors. The 3 P's form the basic triad of Men 1 syndrome. What are the other associated tumors which can be seen in Men 1 syndrome? In 85% of the patients, you can find angiofibromas. In 70% of the patients, you can find collagenomas. Then you can have meningiomas, pheochromocytoma, and lipomas, and adrenocortical tumors can also be present. Sometimes they can also have, many of the times in fact, they can also have neuroendocrine tumors. Okay. So some skin manifestations, if they ask you about Men syndrome, remember that angiofibromas and collagenomas are found in the skin or in the face of many individuals with Men syndrome. Apart from that, meningiomas, pheochromocytomas, adrenal cortical tumors, all of them can be present in Men syndrome. But you have, if they ask you about the 3 major tumors which are found in Men 1, it is your pituitary, parathyroid and pancreatic tumors. Now let us look at each of the tumors in detail. Okay. So the first and most important, the tumor which is found in 90% of the patients with Men 1 syndrome is your parathyroid adenoma. So this parathyroid adenoma is basically as the name suggests, adenoma means benign tumor, which is arising from the parathyroid glands. And what is the hormone that it produces? It is producing parathormone. So what is the normal function of parathormone? Parathormone basically increases the blood levels of calcium and it decreases the phosphate. It promotes the excretion of phosphorus, right? So parathormone basically causes demineralization of the bone and it increases the blood calcium level and decreases the phosphate. It causes increased excretion of phosphate. Okay. So the clinical features with which parathyroid adenoma will present is features of hypercalcemia. Features of hypercalcemia and hypophosphatemia. Okay. So how does hypercalcemia present? Hypercalcemia can cause prerenal AKI. It can cause prerenal AKI. It can cause prerenal AKI. It can cause polyuria. It can cause polyuria. Then it can cause constipation and altered sensory. Okay, fine. So this is how your parathyroid adenoma presents. Now this is a very brief description. When we discuss the topic about parathormone and disorders of calcium metabolism, we will be discussing about this a little more in detail. Okay. So the basic thing is that parathyroid adenoma is the most common in Mechune syndrome and it presents with symptoms of hypercalcemia. So what is the treatment for this parathyroid adenoma? So if it is a localized parathyroid adenoma, then you can go ahead and resect it. But many a time you can just have parathyroid hyperplasia. There are 4 glands, right? 4 parathyroid glands and all 4 can get hyperplasia. So if there is hyperplasia, then it is difficult to remove it and you may have to do a medical management with calcimimetic agents like cinacalcet. Okay, they are calcimimetic agents like cinacalcet. Okay, so that is about your first and the most common tumor, which is your parathyroid adenoma. The second most common tumor is the pancreatic tumors in your Mechune syndromes. So what type of tumors do you find? You usually find pancreatic neuroendocrine tumors. What are neuroendocrine tumors? They basically arise from the neural crest cells. So there are different types of tumors which arise from that. So the first one is your gastrinoma. Gastrinoma is seen in more than 50% of the patients with Mechune syndrome. Okay, so we had briefly learned about gastrinoma in our chapter on Zollinger-Ellison syndrome, in our chapter on peptic ulcer disease. So how does gastrinoma present? Why is it called gastrinoma? Because there is increased production of which hormone? Increased production of gastrin. Okay, so in your gastrinoma there is increased production of gastrin. And how do these people present? They present with multiple duodenal or gastric ulcers. Multiple duodenal or gastric ulcers. They present with ulcers in atypical locations, or they present with ulcers which are refractory to treatment. They present with ulcers which are refractory to treatment. Okay, so this is when you will suspect a gastrinoma in the patient. Alright, fine. So how do you diagnose this? How do you diagnose this? Diagnosis is brought about by fasting gastrin levels. So you use fasting gastrin levels. Okay, so fasting gastrin levels are elevated. If it is more than, the cutoff is usually more than 100, but sometimes there can be a lot of false positive values. So if you do a fasting gastrin level and then you have a screening test which is positive for your Mechune syndrome. The definitive diagnosis is, however, with your somatostatin receptor scintigraphy. This is how you diagnose your pancreatic tumors, which is your gastrinoma. So how do you treat it? Gastrinoma is localized, you can resect it. Many a times it may not be localized. So if it is less than 2.5 centimeters in size, you can do a surgery and you can remove it. But otherwise you will have to do medical management with high dose PPI. Okay, so this is about the first pancreatic neuroendocrine tumor, which is your gastrinoma. The second, you can have an insulinoma. As the name suggests, there is increased production of which hormone? It is insulin. So how will they present? They present with recurrent episodes of hypoglycemia. They can present with recurrent episodes of hypoglycemia. So hypoglycemia in a non-diabetic with hypercalcemia. So these are the ways you will think of Mechune syndrome. Then the next is your glucagonoma. The next kind of neuroendocrine tumor is your glucagonoma. The characteristic rash that you find in glucagonoma is called your necrolytic migratory erythema. So the characteristic rash that you find in your glucagonoma is your necrolytic migratory erythema. So this can also present with increased levels of glucagon, so they may have new onset diabetes. So the treatment is with streptozotocin, some forms of chemotherapy and octreotide. Streptozotocin, chemotherapy and octreotide. Then the next type of neuroendocrine tumor is your VIP-oma. VIP basically stands for vasoactive intestinal polypeptide. Okay, so how does a VIP-oma present? It presents with WDHA syndrome, which stands for watery diarrhea, hypokalemia and achlorhydria. Okay, so a VIP-oma will basically present with large amounts of watery diarrhea and severe hypokalemia with evidence of achlorhydria. This is your VIP-oma. Okay, so how do you treat this? You treat this again with streptozotocin, octreotide or some forms of chemotherapy. So this is about your different types of neuroendocrine tumors which can be found in your MEN1 syndrome. So what are the different types? You can find gastrinoma, you can find insulinoma, you can find glucagonoma and VIP-oma. So the next tumor amongst the 3 P's in MEN1 syndrome is your pituitary tumor. So amongst the pituitary tumors, the most common is prolactinoma. So prolactinoma is associated with increased prolactin production. So you have more prolactin production. So prolactinoma is more common. And secondly, you can also have your somatotroph adenomas or your growth hormone producing tumors. So this is about your MEN1 syndrome's cardinal manifestations. Now let us look at screening. So whom do you want to screen for MEN1 syndrome? So if there is a family history of tumors, there is a family history of your endocrine tumors, then you want to screen them for a MEN1 syndrome. Okay, so how do you do this screening process, right? So you start screening for pituitary adenomas and you start screening for abdominal tumors at least one time a year. Okay, so once a year you will have to screen for pituitary and abdominal tumors, do an abdominal ultrasound for screening. A neck ultrasound should be done at least once in 5 years, and you start doing a thyroidectomy by 5 years of age because many of the MEN syndromes start very early. Start screening for primary hyperparathyroidism by 11 to 16 years of age. So once you know that there is a risk of MEN1 syndrome because this passes on in the family, please do these screening procedures. Now let us move on to your MEN2 and MEN3 syndromes. So MEN2 syndrome is nothing but your MEN2A. MEN2B is called as your MEN3 as well. So MEN2 syndrome is nothing but your MEN2A. MEN2B is also called as your MEN3 syndrome. Fine. So what is the other name for MEN2 or MEN2A? It is also called as Sippel syndrome. It's also called as Sippel syndrome. Okay. So MEN2 or MEN2A is also called as Sippel syndrome, and MEN3 is also known as MEN2B is also known as MEN3. So what is the commonality in all your MEN2 syndromes is that this is associated with a RET gene mutation. So the commonality in all of this is that it is associated with a RET mutation. Okay. So the gene in MEN2 is that cysteine is converted into arginine in the 634th position of your RET gene, where methionine is converted into threonine in the 918th position of your RET gene in your MEN2B. Okay, so this is your basic genetic difference. So let us look at how each of the clinical features are different in your MEN2A and MEN2B syndromes. In your MEN2A, you remember it with the mnemonic 2P and 1M. 3Ps is MEN1, 2P and 1M is MEN2A, and 1P and all M is MEN2B or MEN3. So 3 P's, 2P, 1M and 1P all M. So what are the 2 P's and what is the 1M? 1M is your medullary thyroid cancer. MTC is your medullary thyroid cancer. So you have medullary thyroid cancer in more than 90% of the individuals. Then you can have PTH adenomas and pheochromocytomas. P here is not pancreatic, it is PTH adenoma and pheochromocytomas and medullary thyroid cancer. And in your MEN2B, again you have MTC and pheochromocytomas, but there are a lot of other M's. In 40 to 50% of the patients, you can have mucosal neuromas, marfanoid habitus. Marfanoid habitus means what? A tall, lengthy figure, right? Tall, lengthy figure. And megacolon. So many of these patients have a predisposition to megacolon or Hirschsprung disease, and so they have impaired GI motility. Okay. Then you can have medullated corneal nerves. We know that the corneal nerves are not medullated, so you can have medullated corneal nerves. So these are the features of MEN2B syndrome. So we have MEN2A and MEN2B. So let us look at each of these manifestations again. So in MEN2, you have the triad of 2P and 1M, which is your medullary thyroid cancer, PTH adenoma, pheochromocytoma. In MEN2B, you can have medullary thyroid cancer, pheochromocytoma and all other M's, mucosal neuromas. Then you have marfanoid habitus, megacolon and medullated corneal nerves. The clinical features of medullary thyroid cancer, this can present as a mass in front of the neck. It can present as a mass in front of the neck and cause compression symptoms. And what is the tumor marker of medullary thyroid cancer? You would have learned in surgery. Or in other words, what is secreted by your medullary thyroid cancer? It is your calcitonin. It is your calcitonin which is produced from the C cells of the thyroid gland. This calcitonin can cause other symptoms like flushing. Okay, so this can cause other symptoms like flushing. It can cause weight loss or diarrhea. Okay, so the treatment for your medullary thyroid cancer is mainly surgery. You will have to remove the tumors. Apart from that, since we know that this is because of your RET proto-oncogene, you can give RET inhibitors or tyrosine kinase inhibitors are also given in the treatment of medullary thyroid cancer. Fine. So this is about your MEN2 and MEN3 syndromes. Now let us look at MEN4 syndromes. So MEN4 syndromes have parathyroid adenoma, pituitary adenomas, and remember they have adrenal tumors and reproductive organ tumors, satellite tumors, Leydig cell tumors, some kind of gynecological malignancies like uterine, cervical CA. All of these are part of MEN4 syndrome. Clear? So we have finished what are MEN syndromes. We have MEN 1, 2, 3. MEN 1 is your 3 P's. MEN 2 is your medullary thyroid cancer and 2 P's, pheochromocytoma and PTH adenoma. MEN 3 is your MEN 2B, which has only 1 P, which is your pheochromocytoma, all the other M's. And your MEN 4 syndromes most characteristically reproductive organ tumors. So now that we have learned about MEN syndromes, let us move on to what is Mechune syndromes. So Mechune syndromes is basically multiple endocrine neoplasia and other organ neoplasias. So the first Mechune syndrome that we should be knowing of is your hyperparathyroidism jaw tumor. Okay, it's your hyperparathyroidism jaw tumor, so which has a fibro-ossifying jaw tumor along with hyperparathyroidism because of a defect in the parafibromine gene. The second Mechune syndrome is your VHL. VHL is von Hippel-Lindau syndrome. Von Hippel-Lindau syndrome. Okay, so VHL is von Hippel-Lindau syndrome. What are the characteristic features? How do they present? They present predominantly with ataxia. Why do they present with ataxia? Because as you can see here, there is a presence of a tumor. What tumor is it? This is a cerebellar, because it's in the cerebellum, cerebellar hemangioblastoma. There is a cerebellar hemangioblastoma. Basically, the von Hippel-Lindau gene is involved in a lot of vascular properties. So it's associated with a lot of vascular tissues. That's the reason why you have hemangioblastomas, and in the eye you can have retinal angiomas. Okay, fine. And you have tumors in the lower end of the medulla, you can have tumors in the spinal cord as well, and you can have endolymphatic sac tumors as well. Okay, you can have endolymphatic sac tumors as well. So this is till now what we have learnt about VHL. So VHL basically has multiple endocrine neoplasia, other organ neoplasia. Till now what we saw the other organ neoplasias like cerebellar hemangiomas, spinal hemangiomas, retinal angiomas, endolymphatic sac tumors. So what is the endocrine manifestation of VHL? Your endocrine manifestation is that VHL is associated with pheochromocytoma. VHL is associated with pheochromocytoma. Okay, the gene for VHL is your VHL gene on chromosome number 3 that I forgot to mention. So the gene is your VHL on your chromosome number 3. Okay, so the endocrine manifestation is pheochromocytoma in your VHL. The next Mechune syndrome is your NF1. NF1 is neurofibromatosis. NF1 is neurofibromatosis type 1. Okay, so what are the manifestations of neurofibromatosis? It basically comprises of tumors like neurofibromas. Basically comprises of tumors like neurofibromas. In the eye, what will you find? In the eye, you will find optic nerve gliomas. Then in the iris, you can find hamartomas, which are called as leash nodules. And you find skin lesions in the neurofibromatosis. These are basically pale skin lesions which have a coast of California or smooth borders. The borders of these lesions are smooth and it's called as the coast of California, and these spots are nothing but cafe au lait spots. So can you see here that, can you see this lesion? You have skin colored patches or macules which are called as cafe au lait spots. Then these are benign tumors. Okay, so what are neurofibromas? These are benign tumors which arise from the myelin sheath. They arise from the myelin sheath. So can you see these are benign tumors arising from the myelin sheath which are present all over the body, and this is your neurofibroma. Then this is, can you see, hamartomas in the iris, and this is your leash nodule. And these is nothing but some skin changes which is called as freckles. Freckles where? These are axillary freckles. Okay, axillary freckles. Then your cafe au lait spots, neurofibromas, optic nerve gliomas, all of these are features of NF1. Apart from that, they can be associated scoliosis, and again the endocrine manifestation of this Mechune syndrome is pheochromocytoma and carcinoid. Okay, so this is also associated with pheochromocytoma and carcinoid. Fine? Okay. Then the next Mechune syndrome that you should be aware of is your Carcinoid complex. Okay, is your Carcinoid complex. So what does it have on the skin? It has multiple pigmented areas which are called as lentigenes. It has multiple pigmented areas which are called as lentigenes. Then it has a tendency to form myxomas, predominantly in the heart. So you have atrial myxomas, you can have eyelid myxomas, skin myxomas, tongue myxomas. Then the other benign tumor is the schwannoma, which arises from the Schwann cells. Then you can have Sertoli Leydig cell tumors, and the most common endocrine manifestation is in the adrenal, where you have a PPNAD or a primary pigmented nodular adrenal disease. Okay, primary pigmented nodular adrenal disease, where you have gross appearance of the adrenal will be pigmented and with multiple nodules, and the characteristic feature of this is that there is Cushing syndrome. There is Cushing syndrome, but this Cushing syndrome is also called as cyclical or periodic Cushing syndrome. So this Cushing syndrome is also called as cyclical or periodic Cushing syndrome. Okay, fine. So this is about your Carcinoid complex. So lentigenes, atrial myxoma, adrenal PPNAD and Sertoli Leydig cell tumors are features of Carcinoid complex. The last Mechune syndrome that we should be learning is your Mechune Albright syndrome. Okay, so what is the triad of features of Mechune Albright syndrome? It has polyostotic fibrous dysplasia, where, for example, this is the hip joint and this is your femur. So there is fibrous dysplasia of the femur, and This occurs because of decreased phosphate, and this is what we call as the shepherd hook appearance. This is what we call as the shepherd hook appearance. Okay. Again, you have cafe au lait spots here. The last cafe au lait spots we saw in NF1. The cafe au lait spots which are seen in Mechune Albright have a coast of Maine appearance. It's called as the coast of Maine. So, why is it called the coast of Maine? The borders are very rough. The borders are not smooth, the borders are rough, and hence it's called the coast of Maine. Okay, so how do these terms originate? Basically, California has a smooth coast and Maine is another city which is there in the US, and that has a very rugged coast. That's why this coast of Maine, coast of California. Apart from this, you can have peripheral precocious puberty. You can have peripheral precocious puberty. So, polyostotic fibrous dysplasia, cafe au lait macules and peripheral precocious puberty are all characteristic features of Mechune Albright syndrome. Fine. And what is the mutation? Mutation is in the genus 1 gene, where there is a post-zygotic mutation in the GS alpha subunit of the genus 1 gene. Fine. So, this is your other Mechune syndrome. Okay. So, they can have polyostotic fibrous dysplasia, cafe au lait spot, and the endocrine abnormality that you have is your peripheral precocious puberty. Okay, fine. So, with this we have come to the end of the discussion on men's syndromes and Mechune syndromes. We will be discussing about APS or autoimmune polyendocrine syndrome. So, what is this autoimmune polyendocrine syndrome? Before we move on and start discussing about the types, let us understand this term. So, the term basically suggests that there is an autoimmune problem. There is an autoimmune problem, which means that the body is auto-reacting against what? Polyendocrine. So, against multiple endocrine glands. So, here you have a autoimmune nature to this problem, and there is a polyendocrinopathy. So, there is an autoimmune polyendocrinopathy. So, this is classified into two types as APS1 and APS2. Okay. So, let us look at APS1. So, APS1 basically comprises of the syndrome which is called as APECED. So, what is the full form? The full form is autoimmune polyendocrinopathy candida and ectodermal dystrophy. Okay, so there is an autoimmune polyendocrinopathy, candida and ectodermal dystrophy. So, what is the gene that is involved in APS1? Here you have mutation of the IR gene. Okay, so the mutation of which gene? Mutation of IR gene. The inheritance is in an autosomal recessive pattern. So, the inheritance is in an autosomal recessive fashion. So, what are the characteristic clinical features of this APS? So, APS1 basically comprises of chronic mucocutaneous candidiasis, right? So, APS1 is basically a syndrome which basically starts off very early in age. It can start off by infancy itself. So, it is characterized by chronic mucocutaneous candidiasis. So, chronic mucocutaneous candidiasis means what? They do not have systemic candidiasis. So, if you take a blood culture, you are not going to find candida in the blood. You are not going to find candida endophthalmitis. You are not going to find endocarditis because it's not a systemic infection. Here you have chronic mucocutaneous candidiasis, which means you have skin involvement, you have nail involvement, you can have alopecia, you can have a chronic candida over the tongue, which might simulate a leukoplakia. Right, you might think that this is a leukoplakia, but actually it is nothing but your candida. Okay, so you have mucocutaneous candidiasis, right? So, this starts off in infancy itself. And why do you have predisposition predominantly to candida in this APS1? Because there is an inherent problem or an immune problem where there is a dysregulation. There is a dysregulation or antibodies which are produced to interleukin 17. Interleukin 17 antibodies basically cause what? Finally, there is a deficiency of interleukin 17, and this deficiency of interleukin 17 is the one which predisposes to fungal infections like cancer. So, that is the reason why you have this chronic mucocutaneous candidiasis in patients with APS1. Okay, then more than 80% of the patients, they have this endocrinopathy, which is predominantly hypoparathyroidism and adrenal insufficiency. So they have hypoparathyroidism. That means what will they have? They will have hypocalcemia, hyperphosphatemia. They will have hypocalcemia and hyperphosphatemia. Then more than 80% of the patients will also have adrenal insufficiency. They will have adrenal insufficiency, so they can present with what? They can present with a salt wasting crisis. So they can present with a salt wasting crisis. Alright, fine. 70% of the females and 25% of the males can have gonadal failure. They can have gonadal failure, so they can present with primary amenorrhea. So you're seeing multiple endocrine glands are involved, and the whole pathophysiology is that it is autoimmune in nature. Okay, then you can have autoimmune thyroiditis. You can have type 1 diabetes. Autoimmune thyroiditis, which is nothing but your Hashimoto. So you can finally have hypothyroidism. You can have hypothyroidism and type 1 diabetes, right? So this is about the various clinical features of APS type. Now let us look at the non-endocrine manifestations. Let us look at the non-endocrine manifestations. Apart from these endocrine, the non-endocrine one we already saw, which is your mucocutaneous candidiasis. Apart from that, you can have enamel hypoplasia. You can have enamel hypoplasia, right? In the GIT, there can be autoimmune destruction. There can be autoimmune destruction of enterochromaffin-like cells, the ECL cells, which is your enterochromaffin-like cells which are involved in the production of histamine. So they can be autoimmune destruction of that, which can result in a chronic diarrhea. It can result in a chronic diarrhea. Apart from this, you can have a type of autoimmune hepatitis. You can have autoimmune hepatitis. You can have chronic malabsorption syndromes. You can have chronic malabsorption syndromes. Okay. So this is about your autoimmune polyendocrine syndrome type 1. So you have mucocutaneous candidiasis, and the predominant endocrine manifestations are hypoparathyroidism, adrenal insufficiency, gonadal failure, autoimmune thyroiditis, type 1 DM. And these are your various non-endocrine manifestations. These are your various non-endocrine manifestations. Chronic malabsorption can result in anemia. Chronic malabsorption can result in anemia. Okay. So the basic problem in your autoimmune polyendocrine syndrome type 1 is that there is a genetic defect in your IR gene, and it is inherited in an autosomal recessive fashion, and you have antibodies to interleukin 7. You can have antibodies to interleukin 17. Okay. So how do you diagnose this? How do you diagnose this? So a patient presenting with hypocalcemia, patient presenting with candida, patient presenting with this multiple endocrine syndromes, right? Thyroid, hypocalcemia, multiple endocrine syndromes, then you will have to think of your APS type 1, and you can do a genetic analysis, or you can find interleukin 17 antibodies. So genetic analysis, your IR gene mutation you can find out, or you can find interleukin 17 antibodies. So what is the treatment? Treatment depends upon what is your manifestations. If you have autoimmune thyroiditis like your Hashimoto's, you may have to give thyroid replacement, right? If it is type 1 diabetes, you have to treat accordingly with insulin. So it depends on what type of manifestation you have. Okay. If there is a chronic hypocalcemia because of hypoparathyroidism, you have to give vitamin D and activated vitamin D supplements, calcium supplements. So one thing that you have to remember in the management of APS patients is that this adrenal insufficiency may be masked. Okay. This adrenal insufficiency may be masked by what? It may be masked by your thyroid. Okay. So you know that in APS patients, they can have adrenal insufficiency and autoimmune thyroiditis causing hypothyroidism, right? So if you start replacing your thyroid first, what will happen? So what will happen? We know that TSH basically causes increase in the basal metabolic rate. It causes increase in the cardiac output. Now when you have hypothyroidism, you have bradycardia. Your basal metabolic rate will be reduced. All the functionings of various organs will also be reduced. Suddenly, when you supplement your hypothyroidism patient with thyroid replacement, your heart rate is going to go up, your cardiac output is going to go up, right? So what happens that time? This is going to unmask, it is going to unmask your adrenal insufficiency. So if there is a concomitant adrenal insufficiency with hypothyroidism like your APS syndrome, always treat your adrenal insufficiency. So inadvertently, if you give your thyroid replacement, they will have a collapse, they will have a vascular collapse and they can go into shock. So if thyroid replacement is given before treating your adrenal or your hypoadrenalism or your adrenal insufficiency, then patient can go into shock. So this is a very, very important point. That's why you always treat your adrenal insufficiency and give glucocorticoids before thyroid replacement therapy. Okay, so this is a very, very important pearl that you have to remember in the management of APS type 1. Now let us move on to APS type 2. Now APS type 2 is slightly different from APS type 1 because you cannot localize this mutation to one particular gene. Okay, so you have multiple predisposing factors like HLA-DR2, HLA-DR3, PTPN22. These are all genes which you or HLA predispositions which you see in multiple autoimmune conditions like SLE as well. So it's not that you have only one antibody or it's not that you have only one genetic defect in your APS type 2. Okay. So what are all the various clinical manifestations of APS type 2? So you can have Addison's. Addison's is nothing but adrenal insufficiency. So what is this because of? This is because of an antibody to 21-hydroxylase. So what is this because of? This is because of antibody to 21-hydroxylase. Then you can have autoimmune thyroiditis. This is because of antibody to anti-TP or thyroid peroxidase. Then you can have hypogonadism. You can have type 1 diabetes. You can have alopecia. What is the antibody that you are expecting in your type 1 DM? You can have anti-GAT65 or your anti-insulin antibodies. You can have anti-GAT65 or your anti-insulin antibodies. Other association includes Graves' disease. In your Graves' disease, you have your anti-TSH receptor or your TRAB antibodies. Then myasthenia, you can have myasthenia gravis, right? So you can see multiple other non-endocrine autoimmune disorder association as well in your APS type 2. In myasthenia, what is the antibody? It is your anti-acetylcholine esterase, ACH esterase antibody. Then you can have celiac disease where you have a chronic malabsorption and the celiac disease antibody is your anti-TTG, anti-tissue transglutaminase. Fine. Then vitiligo, pernicious anemia. What is the antibody? You have antibodies to intrinsic factor. You can have hypophysitis where there is an autoimmune destruction of the pituitary gland where you have antibodies to PIT1 or PROP1 which are basically transcription factors in your development of pituitary. Fine. So this is about the key highlighting features of APS2. What you really have to remember about APS2 is that you cannot localize to one gene. It is polygenic and you have multiple antibodies. Fine. So how do you screen? So how do you screen for APS type 2? It is very easy. So depending upon what clinical features that it is having, you can do any of these antibodies and you can screen for APS type 2. So what is the treatment of APS type 2? Treatment of APS depends on what type of hormone is deficient, right? So if you have autoimmune hypophysitis, you may have to give pituitary hormone replacement depending on which hormone is affected, right? How do you look for your pituitary gland intactness? That we have discussed in our chapter on pituitary. Autoimmune thyroiditis, you replace with thyroid. If there is adrenal insufficiency, the same pearl that we have learned for APS1, we have to apply here as well. Always treat adrenal insufficiency first. So always give your glucocorticoid replacement if required, your mineralocorticoid replacement, and then only go and replace your thyroid hormones. Fine. So let us look at the differences between APS1 and APS2. APS1 has an early onset. APS1 can be seen as early as in infancy, whereas APS2 has a later onset. Siblings are often affected in APS1. APS2 has a multi-generational history, multiple parents, grandparents, many of them can have symptoms of APS. APS2 has a multi-generational history. APS2 is more common in females than in males. APS1 has a monogenic IR gene mutation, chromosome number 21, autosomal recessive inheritance. Like I had mentioned, APS2 is polygenic in inheritance, HLA, PTPN22, CTLA4. Okay, HLA associated is DR3, DR4. The autoantibodies which are found in APS1 is to interleukin 17-22. The autoantibodies which are found to APS2, there are no autoantibodies which are found to any of these cytokines. Okay, fine. Then asplenism is seen, there is no immunodeficiency in your APS2. Mucocutaneous candidiasis is seen in APS type 1. APS type 2 has other associations like ITP or myasthenia gravis that we have seen. So this is about the most important features about APS1 and APS2. Thank you.